Hello, everyone, and welcome to Ortho NorCal educational webinar series. We hope everyone is staying safe and healthy. My name is Leah Rutinov, and I will be the moderator for today's webinar. And I'm honored to host this event together with Dr. Kevin Murray and Dr. Christian Haywood, both orthopedic surgeons within Ortho NorCal. Today's webinar topic is shoulder pain and its treatment options, and it is intended for patient education only. We will have Q&A session after each presentation, so be prepared to send the questions over to us using the Q&A button on the bottom of your screen. If you have any additional questions after the webinar, you can always email us at info@orthonorcal.com or call to the office at 408-412-8100. With all that being said, I'd like to welcome our first presenter, Dr. Kevin Murray. Welcome, Dr. Murray.
Thank you, Leah. Welcome. Welcome to everybody listening in today. I'm an orthopedic surgeon specializing in sports medicine, shoulders, elbows, knees. Today we're talking about shoulder and rotator cuff. I'll primarily give an introduction to the shoulder portion, talk a little bit about soft tissue injuries such as rotator cuff, and then move on to Dr. Haywood, who's going to do more shoulder arthritis. So by way of introduction, I'm going to spend a little bit of time talking about the anatomy, the function of the shoulder, particularly what the rotator cuff does. We've heard that term, but maybe not seen exactly what it is. And then as far as medicine, injury, the practical side, presentation, what symptoms mean, how we use the physical exam. And one important thing is different. Is it in my rotator cuff, or maybe it's from my neck or parts of the body, and then finally treatment options. By way of anatomy, shoulder actually joints. We see here the ball and socket joint, the glenohumeral joint, the acromioclavicular joint. That's the end of the collarbone on top of your shoulder. And also we think of a third joint between scapula, the shoulder blade, and the thorax in the back. And going on with anatomy, this shows the muscles around the shoulder. A rotator cuff are the specifically highlighted muscles here. In the front is something called a subscapularis, on the top supraspinatus, and on the back infraspinatus, and also teres minor. We'll get into the biceps tendon also. So I have that picture hand illustration, biceps tendon, and that's an important source of pain also. A deltoid is the big muscle that's on top of the shoulder. Deltoid is what you feel when you feel your shoulder. The actual rotator cuff muscles are smaller and they're underneath the big deltoid muscle. So here I'm trying to give an example, an illustration of how does the rotator cuff work. Now think of muscles on the top, on the back, and they all act like pulleys. So the muscle and tendon in the front will pull and rotate the ball forward, and the back will rotate it backward, and the muscle on the top spinatus will help lift your arm, help lift in terms of the ball and socket joint. When these all compress, when they all tense, they'll compress the ball into the socket and add to the stability of the ball and socket joint. And here we're going to get into what happens when the rotator cuff doesn't work. The slide on the upper left looks at different shapes of the bone on top of your shoulder. What we're looking at, the oval is the socket, and there's a bone on top, the acromion. You can see type 2 and 3. So the acromion bone you would tap on top of your shoulder. Flat 1, it can be down a little bit at type 2, and then it can be curved and hooked a lot, which is a type 3. Type 3 is more associated with conditions such as impingement in the shoulder. Many of you may have heard or may have shoulder impingement. And again, the illustration on the right shows the muscles and tendons added back in. Supraspinatus on the top, subscapularis front, infraspinatus in the back. And here is an example of a progression injury. On the upper left, we're looking down on top of the supraspinatus. This is an arthroscopic down that it's, you can see the fluffy tendon tissue, the white tissue. The next picture to the right shows a small tear in the rotator cuff with an instrument actually placed right through the tear. This is the supraspinatus torn. There's an arrow which shows where the leading edge of the rotator cuff tendon, the white where that should attach is second arrow lower that shows where the rotator cuff tendon should attach. The natural history of rotator cuff injuries is since they tend not to heal, they tend to grow with time. They'll stay the same or grow, not unlike a tear in a piece. So the third picture shows an enlarging rotator cuff tear. And you can see the edge of the tear, kind of an arc around the ball or the ball and socket joint. And the last picture shows a very degenerative, very arthritic shoulder. The rotator cuff has torn so much at this point that you can see both the ball and the socket. And there's a white structure that's come off of the ball and the socket, and that is the biceps tendon. It gives you an idea how the long head of the biceps attaches in a shoulder. So again, from a partially torn rotator cuff to a small tear to a large tear, and what we often call a massive tear, which involves multiple tendons. The picture on the far right shows both supraspinatus and infraspinatus torn from their anatomic attachment points. Getting back to what does the tear mean, you think back to the front, back, and top rotator cuff muscle tendon units, and when they press or when they contract, they'll compress the ball into the socket. And now think back to the last picture where the supraspinatus is torn, the muscle and tendon on the top, that no longer can restrict the ball, the humeral head. And so the humeral head will tend to rise up, not be captured by the top of this rotator cuff muscle tendon unit. The front and the back muscles and tendons still will contract, the top won't, and that allows the ball to escape through the top of the tear. The picture, the X-ray picture on the right shows what happens when a shoulder becomes quite arthritic. The ball has escaped and it's actually touching the acromion. And this is something that Dr. Haywood's talk is going to delve much more deeply into. Just to for completeness, again, you can have arthritis at the acromioclavicular joint in addition to the glenohumeral joint that we just saw. And a condition often associated with the biceps tendon is tendinitis. It's pain to be in the front of your shoulder. This tendon also can tear. Here are examples. Acromioclavicular joint arthritis. Again, think of the articulation between the end of the collarbone, your clavicle, and the acromion. The articulation can become arthritic and have bone spurs, as is shown by the photo bottom of this screen. And looking at the long head of the biceps tendon, you can see that long head of the biceps goes up and passes over the humeral head or the ball and socket. And a lot of times pain occurs when it crosses and makes a right angle turn. That's a potential source of irritation in the biceps groove. The shorter head of the biceps has more of a direct route to where it attaches and is less likely to become inflamed, painful, and damaged. So what happens? What happens when you have an injury to the rotator cuff or biceps? Where is this pain felt? Often you feel pain in overlying the deltoid, the big muscle overlying the shoulder. Pain may radiate down to the outer part of your shoulder. Doesn't necessarily, it isn't necessarily felt right inside of the shoulder joint. Often it's sharp, maybe dull or achy. All these could be related to rotator cuff. Overhead activities, especially those that pinch the rotator cuff and pinch the ball of the ball and socket up under the acromion bone, can be very painful. Stiffness in the shoulder and neck pain, especially pain involving a big muscle between your shoulder and your neck, which is the upper trapezius. Common findings when someone has a rotator cuff or shoulder injury. Generally speaking, strictly rotator cuff injuries does not radiate beyond the elbow and does not cause numbness and tingling in the arm or down to the hand. Those things are more associated with cervical spine and neck issues. So getting back to some basics, range of motion of the shoulder. Usually you can bring your shoulder up in front of you, to the side, and between directly to your side and directly to the front of you, an area in the scapular plane called scaption. This motion is almost always straight up in the air. Externally rotate with your arm at your side about 60 degrees, and internally rotate means reaching behind, and people can usually touch an area just above their lower back. So presentations on physical exam. Physical exam is very important in terms of diagnosing a rotator cuff and shoulder injuries. First, palpate. Where is it sore? Over the rotator cuff? Is it sore over the biceps tendon? Over the acromioclavicular joint? Again, hands-on exam is very, very important to make a diagnosis. Some specific tests, impingement tests, there's a couple of those. Neer's test raises your arm straight up. Hawkins test brings your arm about a horizontal position and rotates your arm and shoulder forward. Both pain when there are rotator cuff issues. Speeds and O'Brien's test, two other tests which are more directed to detecting biceps and biceps labrum issues, and then a cross-arm test, bringing your arm out in front of you and then across body will compress the acromioclavicular joint and cause pain there. So both with palpation and with these tests, we can begin to narrow down where is the problem in a sore shoulder. Strength testing, again, very important. Your doc isolate the supraspinatus, the infraspinatus, and the subscapularis, three main communicators through testing strength, testing resistance in different planes. And then getting into the differentiation between neck and shoulder pain. Again, neck pain, back of the neck, upper trapezius, rotator cuff, located more in the deltoid area. You remember that all of these have a good bit of overlap. That's why it's important to group these together to try to figure out where is the issue. Neck pain, cervical spine pain, nerve pinching from the neck, it may radiate down the arm again past the elbow. Rotator cuff issues tend not to radiate past the elbow. Night pain is not as common with a cervical spine issue as it is from rotator cuff issue. A stiff neck versus stiff shoulder helps differentiate cervical spine and shoulder issues. And what exacerbates these symptoms? Is it more neck issues? Is it more a neck exam, or is it more a shoulder exam and findings related to the shoulder? All right, acute rotator cuff tears. This is the minority of issues, but these are more important in terms of early treatment. A specific injury that causes a rotator cuff tear. And here we have somebody falling on an outstretched arm, which should compress and possibly tear a rotator cuff tendon. They can be large tears depending on the amount of energy, the amount of trauma, and they tend to progress fairly rapidly. Chronic rotator cuff tears, these are tears that develop typically slowly over time. They're found, there's a very high incidence of these type of tears. Over 60-year-old, at least 28%, and maybe half of people over 80 years old have rotator cuff tears. Many of these are not symptomatic tears, even if they're full thickness tears. The groupings of muscles around the shoulder often have been able to adapt. Increasing tear size, the amount of retraction. And remember the earlier small tear, and then the last picture where the tear was retracted all the way to the socket. So tear retraction, atrophy of the muscles that aren't attached aren't used. And atrophy, these are typically more symptomatic. A tear advancing slowly may stay the same. It may be stable for many, many months. It slowly 12, 18 months. To get to the point of rotator cuff arthropathy means the images of the rotator cuff tear that was very chronic and the humeral head had escaped. That can take years to develop, and Dr. Haywood is going to get into that much more thoroughly. So acute on chronic tears may be an existing tear, a very chronic, slow progressing tear, and then an event, even a low level injury event, can cause this to make a rapid jump in how severe the tear is and how symptomatic the tear is. Diagnosis, again, back to the physical exam, history, shoulder pain, shoulder weakness, specific areas of weakness within the specific rotator cuff tissues, an injury that caused a change in terms of function, something that's you're not recovering from. X-rays and MRI is key. MRI is very important in terms of identifying and making a final diagnosis and in terms of soft tissues such as rotator cuff. And we look at tear size, how big is the tear, how much of the tendon has detached from its anatomic attachment site, how much has it retracted, as we saw in some of the images earlier, and is the muscle beginning to atrophy? Is it losing its strength? Is it losing its diameter and cross-section? Is it becoming smaller? So treatment options, again, with any acute injury, rest, activity modification, over-the-counter medications, physical therapy can be very helpful. Injections are of interest. The shoulder and shoulder society has learned much more about cortisone in the past few years. Although it's an effective injection in terms of alleviating symptoms, cortisone is a double-edged sword. A cortisone shot can actually serve to weaken tissue, particularly tissue that's off, particularly the focal corners. In addition, we're beginning to feel that a cortisone shot prior to surgery may result in a lower healing rate and a higher infection rate for the 3 to 6 months following the actual injection. People have heard of platelet-rich plasma and stem cell injections. This seems to be a very promising area. The theory is great. You're injecting material into an area that is a healing material and a material that has potential to regenerate tissue. Right now, the science isn't there to say that this definitely works. There are very few controlled studies which would show that in injecting PRP versus injecting something other than PRP would give a definite edge to the PRP. And again, because rotator cuffs do not heal on their own, or very rarely would be seen to heal on their own, eventually, with enough dysfunction and disability interfering with activities that a person would want to do, surgery may become necessary. Surgical treatment, the image on the left shows an arthroscopic surgery with a camera in the shoulder, tools in the operating room, and the image on the right shows a mini open rotator cuff. This will show you the anchor that's been placed in the anatomic attachment site of the rotator cuff of the supraspinatus, and the sutures that are attached to that anchor. These sutures eventually will be passed through the rotator cuff in order to secure it back to its normal location. AC joint treatment. Surgery for the AC joint involves literally resecting the end of the clavicle so that this arthritic joint no longer contacts, the bones don't contact each. Usually that's done at a trial of physical therapy, ensuring that we know this is pain generated. Arch decompression, another surgery. This can be done for impingement. It's becoming less and less popular because we're feeling in the shoulder society that it's less and less effective as far as a pain reliever, but it done for acromion, that spike of bone coming down from the acromion. So biceps tendonitis, tenotomy versus tenodesis is an ongoing debate. Both sides are very effective in terms of pain relief. A tenotomy means divide the biceps tendon, take pressure off the biceps and the labrum where it is attached in the shoulder. Make a bit of activity that's more dividing. Let's see, summary covered the anatomy and function of the rotator cuff and the shoulder, presentation of symptoms, exam finding, imaging studies, how to differentiate shoulder rotator cuff pain from neck pain, and then treat about shoulder rotator cuff anytime you suspect that there is a problem, something interfering with your daily life. Thank you very much. I look forward to all of your questions after Dr. Haywood's talk.
Thank you, Dr. Murray. Very nice presentation. We're gonna switch and I guess welcome Dr. Haywood, and we'll address all the questions at the end of Dr. Haywood's presentation. Welcome, Dr. Haywood. You can share your screen, right? Okay, there you go. Can see your screen.
All right. Thanks to Dr. Murray. Can you hear me okay, Leah, and everything?
Yes, everything's great.
Okay. So I appreciate Dr. Murray's discussion on the function of the rotator. Definite role in speaking about arthritis and the various ways in which we treat shoulder arthritis. Just as an overview of what we're looking at here, I thought I'd talk just briefly. He covered the function of the rotator cuff very nicely, so we'll just briefly touch on the anatomy. But as a general rule, his point is well taken when he talked about acute versus chronic problems. He discussed tendon tears, which is the rotator cuff, also possible dislocation fractures. I'll be speaking more about arthritis, which can result as consequence or sequela of rotator cuff injury, but also without rotator cuff injury, as a number of other things can lead to arthritis in the shoulder. We'll talk about that briefly. And so, as he mentioned, the shoulder is generally referred to as a ball and socket joint. That being said, the ball and socket joint in the shoulder is rather unusual and quite different from the other ball and socket joints like the hip, in that the socket's very small and the ball is very big. And the rationale or the advantage to that is it gives you more range of motion than any joint in the body. The shoulder has the most amount of range of motion. We sometimes refer to it as a golf ball sitting on a golf tee. It's not quite that exaggerated, but that's the general idea. And with that advantage of having range of motion comes the disadvantage, and that disadvantage is that it's rather unstable. The ball can come out of the socket, and you hear about people dislocating their shoulder quite frequently. It is the most dislocated joint. And so to prevent that, of course, you have a number of ligaments holding it in place, but probably more importantly is the muscles of the rotator. He went over all those, won't dwell on it, but so to say that the primary function, of the rotator cuff as they're pulling is to hold the ball centered in the socket. The whole phenomenon of how they work in unison with the larger muscles around the shoulder, specifically the deltoid muscle, is referred to as the force couple, meaning that the rotator cuff is functioning in its capacity to contract and hold the ball centered in the socket, while the deltoid, the latissimus, and the trapezius are working in their capacity to actually move the humerus around, and they do the bulk or the majority of the heavy lifting, so to speak, when it comes to motion of the shoulder joint. You need both of those to be functioning in order for the shoulder to function. On top of that, if you imagine or you understand that while all of that is happening, the scapula itself, where the socket is located, your shoulder blade, is actually moving as well, and it's moving across the back of your thorax. And so there's a lot of motion going on in multiple planes and in multiple facets with multiple muscles. And that's sort of the beauty and the complexity of the shoulder joint, each of which provides a very important purpose. So today I'm talking specifically about shoulder arthritis. Arthritis is a term, broken down means, inflammation of the joint, of course, and it can be represented in a number of different ways. But generally, when we say arthritis, we're referring to osteoarthritis, which is a sequential loss of the cartilage coating on the surfaces of the joints that does lead to inflammation in the joint and pain. When we're looking at arthritis and discussing it and classifying it, probably the best thing or the easiest way to understand it is to look at an radiograph. The X-ray on the left shows a normal shoulder, and the X-ray on the right. And what I generally tell patients is, as much as looking at the bones themselves, whenever an orthopedic surgeon is looking at X-ray, we're looking at the space in between the bones, because it tells the ball and socket there on the left-hand photo. There's a really nice space in between those two bones. And what's in that space, what you don't see on an X-ray, is the cartilage. There's a layer of cartilage on the socket, also called the glenoid. It's a layer of cartilage on the humerus. And cartilage touching cartilage is how most joints function. And it's very smooth. It's very pain-free. There's a concept called the coefficient of friction, if you remember from physics, which is the way in which a substance applies friction when in contact with another substance. And the amount of friction between two cartilage is actually less than ice on ice. And so that's how joints are supposed to move, very smoothly. In contrast, on your right-hand side, you see X-ray of a shoulder where you can see the socket and you can see the ball, but you see absolutely no space in between the two. On top of that, what you do, you see the bite, that's increased density. That's a reaction of the bone itself, the density of the bone, increasing the density to compensate for the fact that it's now seeing more pressure than it's used to. It's not being protected by the cartilage. So now the bone itself is seeing more joint contact pressure, and it compensates by a couple of different ways. Number one is sclerosis, making the bone more dense. And that's why it looks so white there. And number two is by making bone spurs or osteophytes, which you do see there at the bottom part of the joint. And so that is essentially what we refer to as osteoarthritis. And we're just speaking specifically about that cartilage coating on the bone, whether you're in the hip or knee or ankle, or in this case, the shoulder. That's at play here. Articular cartilage tissue, and it can be damaged in a number of different ways. We call it an insidious onset of pain in a joint. You can see these are arthroscopic images actually of a knee, but I put them up because they demonstrate really well the idea of an acute injury to cartilage versus a more chronic injury. What you see on the left-hand side is an arthroscopic picture between the tibia and femur and a knee. And that yellow part is bare bone on the tibia and then bare bone again on top on the femur. And so you have bone touching bone in that case, which will become very painful. And you can see the ragged remnant of cartilage around the outside. In contrast, you can have an acute injury to cartilage, which you see on that picture on the right. And that's an arthroscopic picture, once again, of a knee. You can see bone below, and that can happen from generally due to a traumatic injury to the joint rather than repetitive use, genetics, accumulation of trauma. So cartilage is a very unique substance. You know, I talk to patients a lot about, you know, tissues in the body, and some tissues are very healing friendly and some are not. Probably the two tissues in our body that are least likely to heal, least likely to generate, therefore treat in terms of generating tissue is nerves and cartilage. Nerve tissue is incredibly difficult to reproduce, to heal, to grow, and that's why, you know, paralysis is generally considered to be a permanent condition. An area of active research, obviously using modalities such as stem cells. And cartilage is very similar. There's some unique natures of what we call hyaline cartilage, which is the cartilage on the surface of bones in the joints. And it's mostly made up of water. The manner in which cartilage buffers joint contact pressure, think of the knees or the hips, the way it cushions the weight of the body against gravity, mostly with hydrostatic pressure. So it's mostly up to 80% water, particularly when we're younger, water content. There are other components in the cartilage, one of which is collagen. It's a type 2 collagen. It's different than the collagen we have in bones and tendons. It's a collagen specific to crystals. Help to read and structure also the anatomy of the clear understanding of how much. I've seen estimates as high as 75% of your chance of developing arthritis being due to your genetic makeup. So again, high cartilage, it's a couple of reasons, additional reasons why it's so poor to heal. It's avascular, meaning it has essentially no blood supply. All the nutrients that the cells need, they get through osmosis from the joint fluid itself. It's aneural, meaning there's no nerves in the cartilage itself, as well as alymphatic.